My name is Dr. Jeff Lancet. I'm the head of the Leukemia Program at the Moffitt Cancer Center in Tampa, Florida, and I will be discussing and reviewing the final results of our recently presented Phase 3 randomized trial of CPX-351 versus standard 7+3 in older patients with newly diagnosed high-risk AML. To begin with, CPX-351 is basically daunorubicin and cytarabine, two very old drugs that are incorporated and developed into a synergistic fixed molar ratio and incorporated into a liposome that then allows for the drugs of interest, in this case cytarabine and daunorubicin, to be delivered to the target cell in that specific synergistic ratio associated with the highest likelihood of cell kill. So it's really a drug delivery system that's being optimized here. The Phase 3 trial that we performed is shown here in this study schema slide, and the eligibility for this trial included patients who were previously untreated and between ages 60 and 75 years. These people were relatively fit, in other words, able to tolerate intensive therapy and willing to undergo intensive therapy. The patient population was a high-risk population defined as patients with therapy-related AML, patients with AML and a history of myelodysplastic syndrome, patients with AML and a history of chronic myelomonocytic leukemia, or patients with de novo AML with an MDS-related karyotype. These were also the stratification factors that were used in the study, these different subtypes of high-risk AML that I just described, and we also stratified patients based upon age, below age 70 or ages 70 and higher. Patients received up to 2 cycles of induction therapy, followed by up to 2 cycles of consolidation therapy if remission was achieved, and then they were followed for up to 5 years or until time of death. And the primary endpoint of the study was overall survival. In the next slide, we've depicted the treatment schema itself, and you can see that the CPX-351 arm and the 7+3 arm were inclusive of induction, reinduction, and consolidation. I would point out the fact that the cumulative dose in the CPX-351 arm of daunorubicin was lower overall than in the 7+3 arm because of the dose equivalent of daunorubicin in 1 unit of CPX-351. In the next slide, we've shown the patient characteristics, and you can see that the patients were very well matched amongst different demographic variables, including age, performance status, cytogenetic risk category, and other stratification factors. Shown in this next slide here are the primary efficacy results, and in this particular trial we observed that the survival was longer for patients who had received CPX-351 compared to patients who had received 7+3. And the median survival was about 3.5 months longer for CPX-351, as you can see here. And just as importantly, the hazard ratio for death was lower for the CPX-treated patients compared to the 7+3 patients. In other words, over the entire course of the study, there was a 31% decreased risk of death in favor of the CPX-351 treated patients. In the next slide, we demonstrate also that event-free survival was statistically improved in the CPX arm compared to the 7+3 arm, although the event-free survival median was more modest than the overall survival improvement. In the next slide, I've shown that the CPX drug induced a higher response rate than 7+3 treatment, both in terms of complete response rate and overall response rate, and these results were statistically significant. In the next slide, I've depicted one of the key elements of toxicity for this trial, and that being 30 and 60-day mortality rates. And what we determined was that the mortality rates seemed to be lower for CPX-351 and versus 7+3 for both the 30 and the 60-day time points. So this indicated that there was not any type of early safety signal associated with CPX-351 in a negative way, and perhaps it might be the other way around, that the early mortality could be higher with 7+3. In the next slide, I'd like to point your attention to the hematologic toxicity profiles that were assessed in this study, and namely being related to time to complete or partial blood count recovery, as determined by neutrophil recovery to greater than 500 or platelet recovery to greater than 50,000. And similar to what we found in the phase 2 study that we had performed previously, in this current study, there was approximately a 7-day delay for neutrophil and platelet recovery in the CPX arm compared to the 7+3 arm. Despite this delay in count recovery, as I mentioned just previously, we did not observe any increased risk of early mortality in the CPX-treated patients. I wanted to spend a little bit of time also discussing the role of hematopoietic stem cell transplant in this patient population because it is often considered part of the continuum of care for AML. And this next slide depicts the characteristics of patients who underwent transplant. And as you can see, the numbers were similar between the CPX and the 7+3 arm. In fact, there was a slightly higher percentage of patients in the CPX arm that eventually underwent transplant. In general, the patients were well matched amongst baseline characteristics, with the exception being that a higher percentage of older patients, meaning patients between the ages of 70 and 75, were transplanted from the CPX arm compared to the 7+3 arm. And as you can also see, the majority of patients in both arms were transplanted in a state of remission. The sensitivity analysis that we performed by censoring patients at the time of transplant demonstrated a trend towards improved survival amongst patients who were censored prior to transplant that favored CPX-351 compared to 7+3, although the numbers were smaller, of course, and the results were not quite statistically significant. But in order to really develop an exploratory understanding of how CPX-351 might positively influence outcomes after transplant, we performed a landmark survival analysis at the time of the transplant for those patients who actually did undergo transplant. And as you can see in this next slide here, that although the numbers are small, survival after transplant seemed to be significantly higher amongst patients who had received CPX-351 compared to patients who had received 7+3. And the reasons for this are not entirely clear, but nonetheless, there seemed to be a survival advantage following transplant in favor of patients who had received CPX-351 as part of their initial therapy. So in conclusion, we feel that CPX-351 was superior to 7+3 in all of the key efficacy parameters, including overall survival, event-free survival, and response rates. The early mortality rates appeared to be lower in the CPX-351 arm. The overall safety profile was comparable. The outcomes following stem cell transplant appear to favor CPX-351. And finally, we feel that CPX-351 should be considered standard frontline therapy of older patients with high-risk AML. Thank you very much.